not able to give them the maximum dose because of the cardiac events. What if they are not able to tolerate the dose? Even for a small dose of teralifil, they are having severe headache, backache, or even gastric upset. What are the options there? Next. Traditionally, the vacuum device and the on-demand intracavernosa injections were available, but culturally it is still not yet accepted in our part of the world. If not that, then there is the last option is a surgery. Although there is a increasing acceptance towards the surgery, but still a lot of stigmata are still hanging around that. So what are the options for these patients? So this is the era of regenerative therapy. The regenerative therapies like growth factor injections into the penis and shockwave therapy for the penis. So they serve to bridge the gap between the injection, vacuum device and the penile processes. Attempt is made to restore a man's natural erections. Before we term a patient as a PD5 non-responder or a PD5 failure, these are the certain factors what we have to take it into consideration, whether adequate stimulation was there, because the people think that once a tablet is taken, okay, Viagra is popped in, there will be instant erection. No, there has to be good adequate stimulation, whether adequate dose was used and whether adequate time was there, and what was the thing with respect to diet. These are the factors which has to be taken into consideration, and provided all these were there and at least 6 times. Now the thing is totally changing to 4 doses. 4 doses, then we can actually term the patient as a PD5 failure or a non-responder. Looking at the newer therapies, so penile shockwave therapy. This is not a current shock into the penis. These are all completely sound wave therapy, a simple outpatient procedure which is given to the penis directly. So this is not something new to our field. It started with urology. These type of waves are used for breaking the stones, what we call as the ESWL. Later, the same thing has been adopted in orthopedics for the various tendinitis and other pain syndromes. Early 2000s, it was introduced in cardiology. It was found that it causes the significant improvement in the angiogenesis. Based on all this, first in 2010, it was introduced for the treatment of erectile dysfunction. So how it works is that, so it's a simple outpatient procedure where the shockwave therapy is given to the OP directly. Onto the penis directly. So these ways, what it happens at the cellular level is that reduces the inflammation, increases the overall blood flow, it causes improvement of nerve conduction. So that is also cavernosal remodeling, reduces the sympathetic tone. So on the whole, the overall blood flow to the penis increases. The documented success rate is about 40 to 80%. There is enough data to tell that these therapies work. So this is not something new which has been in the last 5 years or 6 years. As I already told, almost it's been into the field for more than 15 years. So there is enough data to prove that it overall improves the quality of erection, the quality of, and subsequently the overall quality of life improves. More importantly, patients who are not responding to PD5 inhibitors they start becoming responsive to PD5 inhibitors again. So this is a very good thing, so that we can still prolong the surgery, and some people may not need surgery at all. Once they cross 60, they will not be interested in sexual life, so that it can be postponed. And being a simple procedure, so it hardly takes, one session hardly takes about 15-20 minutes. The patient can just walk into the OPD, walk into the hospital and then leave within half an hour. So there are no significant complications associated. It is very useful in the acute phase of Peyronie's disease as well. Based on all these things, since 2023, it has been inducted into the European Urology Guidelines as well for the use of vasculogenic ED. I would like to share my experience with the shockwave mission. The center where I got trained for my andrology fellowship. My mentor has been using these devices for nearly 10 years. I had the opportunity to compare devices, because there are multiple devices available in the market, which produces a radial wave, which produces a electrohydraulic wave, which produces an electromagnetic wave. Electromagnetic waves are the recent one. I had an opportunity to explore all this and see his patient follow-up. How long, how many therapy the patient, how many sessions the patients needed, how long it has to be given, and what is the duration of this effect. Whatever is it, that's the first question patient will ask me. Sir, இப்போ நான் எடுத்துக்கிட்டா எனக்கு கம்ப்ளீட்டாக சரியாயிடுமா? illa na thirupi edukanuma. I was able to explore all this thing, and once I'm back and back to my center, here we brought in India's first and the latest device, shockwave machine. So by God's grace, till today, although the acceptance kind of only partial, I was able to do about the 30 cases of for erectile dysfunction. Here, the mild to moderate erectile dysfunction group, they improved well after a period of 3 months. They do not need require the need of any PDE5 inhibitors. However, the moderate erectile dysfunction group, they required some amount of PDE5 inhibitors. I either give them only 2.5 or maximum 5 milligrams sildenafil daily, and they are extremely happy with the dose. And my most satisfying patient was the patient with the severe erectile dysfunction. He's been using, previously before coming to me, he used to use the vacuum device. Vacuum device is, according to me, is one of the dreaded device. The patient will feel the penis is entire blue, it's cold, it's becoming numb. For that, he's taking a full dose of sildenafil and about 10 milligrams of tadalafil every day. Otherwise, extremely healthy person, extremely good heart, he is able to comfortably have penetrative sex. And apart from these indications, what other this shockwave machine can do? It is extremely helpful in acute phase of Peyronie's disease. Obviously, acute phase, you are not going to go operate, but the patients will have a lot of pain. At that point, Peyronie's disease of pain, so the shockwave therapy is extremely helpful. And also patients of chronic prostatitis and CPPS, chronic pelvic pain syndrome, they do not respond to the conventional medications. Antibiotics do not work, alpha blockers do not work, but this does magic to them. Next is about the PRGF injection, which is basically platelet-rich growth factor injection, the commonly known as the P-shot, which I feel is one of the most abused treatment in erectile dysfunction. What is this basically PRP is? So PRP basically it's concentrated plasma which has a platelets of about 3 to 7 times on the baseline. Just please give me 5 minutes, I'll be done. Yeah, so how it works is that once it's injected into the tissue, so there is the platelet activation, and it exerts its effect via the various growth factors. The important growth factor here is the VEGF, which has been associated with, which has been extensively studied to overall improve the blood flow and improve the erection. As for what is the current status, it's still not recommended by any of the standard bodies for use in erectile dysfunction. It is still considered only as a off-label indication. I would like to share my experience here. So with my mentor, Dr. Vasan, one of the senior most andrologists in India, we did a unique study. We did a study to quantify what is this VEGF levels in patients with erectile dysfunction and the patients without erectile dysfunction. And from this, as a corollary, can we arrive at a dose to treat erectile dysfunction? We presented our findings in the various international societies and as well as the national societies. So what we have concluded so far, still it's unpublished data. We are in the process of getting it published. So just by drawing 10 to 20 ml of blood to make a PRP, which is being practiced for the hair growth purposes, it is not sufficient for the erectile dysfunction. And the levels of VEGF in the erectile dysfunction patients were found to be lower when compared to patients without erectile dysfunction. So the levels of VEGF required to improve erection are very high. As a part of the next study, we arrived at an arbitrary dose of this supraphysiological dose. We estimated the VEGF levels and actually categorized into these two categories and administered to the patient. We follow the patients at 1 month, 3 months and 6 months. From 3 months onwards, the patient started showing good response, which has been proved both qualitatively and quantitatively. Lastly, if nothing works, the penile prosthesis surgery is there. So what happens during erection? So if there is no blood into the corpora cavernosa, he is not going to have the erection. So what we do here, we place 2 artificial tubes into the cavernosa so that he'll be able to perform, he'll have his orgasm, he will ultimately ejaculate. Process, obviously it is not something new. Process has been in the industry for so many years, but it has been refined. Now we are at the peaks of being refined. So there are two types of processes available. One is a malleable processes and another is a 3-piece processes. So, sorry. Can you just play it again? Sorry. எப்படி இப்போ மேலே போகிறது இப்போ ப்ரீவியஸ் எப்படி போகிறது ஐ வாண்ட் ஜஸ்ட் கோ டு okay fine okay right. So basically the three-piece processes, this works on the principle of hydraulics. So there's a small scrotal pump, the pump which is placed inside the scrotum, and this goes into the abdomen in the preperitoneal space. It will be completely concealed, nothing will be seen outside. So these are the most simpler versions, which are medical grade silicone, and it has a central nitinol core. So how it works, I just have a brief video to demonstrate. Once a man wants to have an act, so he will activate the pump which is placed inside the scrotum. So this will mimic something called the natural erections, which has been completely flaccid, and after pressing it, he will achieve good erections. Once the act is done, he will press a button in the scrotum so that it goes back. So that's why he will feel the penis stretching and the penis coming down. So that's why this is considered as almost near normal. But the next one, although the purpose is same, but the quality and the comfort varies from person to person. In this, the penis will always be big. So once a person wants to have an act, he has to make it straight, perform the act, and once it is done, it can be bent and concealed. So what are the advantages of the prosthesis surgery? It is a one-stop solution, single-time cost. Patient will not be needing any more medications or any more treatment after that. It's a simple outpatient procedure, durable outcomes. The recovery is fast. They can start using the prosthesis from 6 weeks onwards. The patients, importantly, the natural length and the girth will be preserved. Then the overall satisfaction rate. Here, more than the men undergo the surgery not for their satisfaction. It's to satisfy the partners. The reported partner satisfaction is more than 90%. And these implants last for almost 20 years, and they also come with a warranty as well. And hence the overall quality of life is also improved. So just to conclude, based on all the impact what erectile dysfunction can do, this should be considered as a serious issue in every person's life. The lifestyle factors are becoming the most significant cause of erectile dysfunction, and while evaluation of erectile dysfunction, the patients at risk of developing cardiac events can also be identified, and there are multiple treatment options, even the regenerative therapies, so that the patients, the men, need not be in the darkness anymore. And lastly, you being the family physicians and the diabetologists, who are the first point of contact for the patients, will have to guide the patients necessarily adequately, so that we can overall improve the quality of life. Thank you very much for your patient listen.
Thank you, sir, for the informative session. The floor is now open to questions from the audience.
According to one Harvard study, intensive or moderate exercise improves by 41%.
Sir, yes, sir. So everything has to go hand in hand, sir. So these treatments will not work if we don't treat the primary cause well. So the primary cause has to be treated definitely. Always in my prescription, I write the first line as lifestyle modification, and I tell the patient that if this does not work, all other therapies will not work for you. Obviously, everything has to go hand in hand, sir. So there are things obviously like pelvic physiotherapy, Kegels exercises. All this, what it does is that it just increases the blood flow, sir. So that's it. But this alone is not going to help. It will just only be a part of the treatment, sir.
And most of the time we get the patient, young individual with erectile dysfunction.
Yes, sir.
And these people probably may not be having this the anatomical problem, maybe a functional. They are very much anxious, very much depressed, because they don't have feeling, libido, all these things. Probably if you put SSRI, serotonin reuptake inhibitor,
Yes, sir.
that improves. So any person who comes with the ED in a young individual, otherwise normal, if you put him on the antidepressants is a minor small dose with the reassurance, with of course lifestyle modification, they improves with along with these inhibitors like PGPI
Yes, sir.
inhibitors. Yes. How do what is your take on this?
So in this scenario, sir, like as you rightly told, okay, but the trend is slowly changing, sir. So they are becoming early diabetic or dyslipidemia. LDL almost close to 180, 200. So the things are changing this way, sir. So these tests, we have the periscope machine in our hospital. So this helps me to identify the vascular resistance. If everything is normal, obviously first is going to be reassurance. He will need counseling, obviously, and then a little dose. I use bupropion. So bupropion will actually will work well in this patient, and I'll give him a very low dose of a daily PDE5 inhibitor, not on demand, because the on demand what is doing is that it's creating a psychological dependence for them. மாத்திரை எடுத்தாதான் வேலை செய்யும் இல்லனா வேலை செய்யாது. They are being pushed to, especially these group of patients. So in these patients, I don't prefer that. Just a low dose of tadalafil and then some anxiolytic. So they start doing well. Once they are consistently they are able to do well, that creates a positive info. Stop all medicines. Over.
Thank you, sir. Thank you so much. Unfortunately, we'll have to conclude the session due to time constraints. Thank you very much,
Thank
sir.
you very much.
Guiding us steadily through to the best approach to dizziness and diabetes, we have with us today Dr. S. Muthukani, who will be taking over the next session. Sir, we welcome you.
Dr. S. Muthukani, sir. He is a consultant neurologist and epileptologist at Apollo Hospital, Chennai. His major achievements is a conveyor S subsection of IES. Also started the epilepsy surgery program in including the long-term video EEG for the first time in South Tamil Nadu. Sir, we welcoming you.
Thank you for the kind introduction. At the outset, I would like to thank the organizing committee for giving me this wonderful opportunity. I will also like to thank my guru, Dr. S. Meenakshi Sundaram from Madurai. The topic which was given to me is clinical approach to dizziness in diabetics. After that excellent talk about sexual and reproduction by Dr. I hope you have some interest in learning about dizziness in diabetics. Let's move on. This is the outline of my talk. I will introduce the common terminologies we use in dizziness. I will try to use some case scenarios which will be interesting to know about the clinical pearls, and finally some take-home messages. We all know that vertigo is a disorder of motion perception, and you have two types of vertigo. One is a spinning sensation, it's called spinning vertigo, and another one is the patient will be feeling some kind of swaying, tilting or bobbing. It's called non-spinning vertigo. And many times the patient would use the term dizzy. It might mean hundreds of things, so you need to ask the patient exactly what they are trying to convey to you. What is acute vestibular syndrome? The term was initially coined by Dr. Hodgson and Bellow in 1998. This syndrome is defined as when there is a sudden onset continuous vertigo which is lasting for more than 24 hours and associated with nausea and vomiting, and the vertigo will be worsening with the head movements. This is how it is defined. But the duration of lasting for more than 24 hours may not be applicable in the emergency setting because the patient will come to the emergency with continuous vertigo. So this is a real life scenario. A patient comes to the doctor with dizziness for the last 5 days, and the doctor, after doing cursory examination, is saying that, okay, I made the diagnosis, you have a disease called vertigo. And the patient is asking, what next, doctor? And the doctor is prescribing beta histine and cinnarizine and asks the patient to come back after 2 weeks. The patient comes back and saying that the symptoms got better but not completely relieved. And the doctor is saying that you take twice the dose and come again after 2 weeks. But it goes on and on. Finally, the patient is saying that, doctor, I am not getting completely cured, and the doctor is saying that you please go and see the psychiatrist. Here, who must see the psychiatrist? See, we should understand that vertigo is a symptom, it's not a diagnosis, and we need to search for the diagnosis. We'll move on to the case scenarios. They are all real life case scenarios. We had a 55-year-old male, known diabetic and hypertensive, presented with acute onset vertigo since 1 hour. They came to the emergency thinking that they probably had a stroke and IV thrombolysis would help them. The patient was describing that he had a spinning feeling with nausea and vomiting with difficulty in walking. There was no past history of vertigo. He was a smoker but no alcohol abuse. Before moving on to this case, we need to understand few facts. We all know that we use the score ABCD2 in emergency when the patient comes with a stroke. But we should understand that if you use ABCD2 score in a patient with acute vestibular syndrome, there is a chance that 40% of the stroke get missed and you may overdiagnose stroke in another 40%. So this is not a very useful score when the patient presenting with acute vestibular syndrome. And another score which we use in emergency for stroke is NIHSS, National Institute of Health Stroke Severity Score, and in that vertigo is not included at all. So if you use NIHSS score, the posterior circulation stroke would get completely missed. Then how do we proceed in this case? What are all the clinical clues to diagnose whether it is a peripheral problem like vestibular neuritis, which is a benign condition, and posterior circulation stroke, which is a very dangerous problem and we need to tackle the problem as early as possible. The clinical clues would be HINS. What is HINS? The H and I stands for head impulse test. What we do in that, it's basically testing the vestibulo-ocular reflex. So here you just hold the patient's head and ask the patient to fix on your nose, and you turn the head to either side by around 15 degrees. So what happens when the vestibulo-ocular reflex is normal, they will be able to maintain the position of eye fixing, but in the presence of abnormal vestibulo-ocular reflex, they will develop a catch-up saccade. So I'll use this video to show. So here we are holding this patient. When we turn the patient's head to the right, he was able to maintain the eye position to your nose. But when they turned the head to the left side, you can see that there was a catch-up saccade. So this indicates that it is a peripheral vestibular disease rather than the central disorder. Positive head impulse test indicates it's a peripheral vertigo, and in central disorders usually spares vestibulo-ocular reflex except only one condition, that is stroke due to ICA artery occlusion, antero-inferior cerebellar artery occlusion, where it supplies the vestibular apparatus, so it produces labyrinthine ischemia, and the patient would present with abrupt onset deafness, vertigo, and cerebellar features. So what is the N stands for? N for nystagmus. So I'll give you a few examples. Here you can see that in the primary position you can see a horizontal nystagmus with a torsional component and it's beating towards the right side. And when the patient was looking to the right, you can see that the nystagmus got potentiated and it was still beating towards right with a horizontal with the torsional component. Even when he was looking to the left, there was still nystagmus was present. So when there was a spontaneous nystagmus with a horizontal with a torsional component, and it indicates it's probably a peripheral vestibular disease like vestibular neuritis. Here you can see this patient, when he was looking to the right, you can see that there was a right beating nystagmus, and when he was looking to the left, there was a left beating nystagmus. So here the direction was changing, but it was purely a horizontal nystagmus and there was no torsional component. It's a gaze evoked and direction was changing. When he was looking to the right, right beating, when he was looking to the left, left beating, and it was associated with the cerebellar features. So it indicates that it was a central cause of vertigo and the patient had a right cerebellar hemorrhage. And finally the TS stands for test of skew. Skew is nothing but there was a vertical malalignment of the eyes. Here you can see that the right eye is in the middle and the left eye is shifted downwards. This is called skew. When it is present, it indicates it's a central disorder of vertigo. By using this test, you will be able to diagnose whether it is a peripheral problem or central problem, and it is almost 97 to 99% sensitivity and specificity. We should understand that even MRI can be negative in up to 20% of the patients with the posterior circulation stroke in the first 48 hours. So the negative MRI also may not be able to help you to rule out posterior circulation stroke. What is HINS plus? Along with the HINS, that is head impulse test, nystagmus and test of skew, if you add finger rub to check the hearing, then it indicates it's a HINS plus test, and it will be positive in anterior inferior cerebral artery stroke, that is ICA territory stroke. The another algorithm which we use commonly is standing algorithm. Here, other than the head impulse and the nystagmus, you assess the truncal ataxia. What you ask the patient? You ask the patient to sit and stand unassisted. If there is a central disorder, they will have difficulty in standing and difficulty in walking. And we also use some provocation maneuvers, especially when you are suspecting a BPPV clinically. So we all usually fear about missing stroke in the emergency setting, isn't it? But if you look at the statistics, only up to 4% of the patients with the dizziness in the emergency have actually stroke. So it's like unnecessary fear of a bad decision will be a major stumbling block to make good decisions. And another common myth is when the patient is presenting with a recurrent vertigo, the emergency physician usually suspects it may be a recurrent TIA. Here you should understand that this is the basilar artery, and from the basilar artery the anteroinferior cerebral artery comes, and from the anteroinferior cerebral artery the internal auditory artery comes, and it divides into vestibular artery and supplies the vestibule. To present as a recurrent vertigo, then embolus has to travel all the way to the basilar artery, take 90-degree turn to the anteroinferior cerebral artery, take another 90-degree turn, goes into the vestibular artery to produce isolated vertigo. So when the patient is presenting without cerebellar or cochlear involvement, isolated vertigo as a recurrent TIA is very, very unlikely. We will move on to the other patients. 65 years old male, known diabetic and alcoholic, presented with altered sensorium to the emergency, and before having this altered sensorium, he was complaining of dizziness, palpitations and sweating, and he was very much irritable. And in emergency, the score was around 9/15, blood pressure was okay, and there was tachycardia. So what do you suspect in an alcoholic patient and diabetic? So you need to check the blood sugar, and the blood sugar was found to be very low. So we all know that it is a hypoglycemia presenting at recurrent dizziness. So we need to give thiamine before loading this patient with the dextrose to avoid precipitating acute thiamine deficiency, and the patient has recovered completely. We need to define, we need to categorize this patient into any of these 4 categories. The category 1, when the patient is presenting with a loss of consciousness, it may be because of syncope or seizure. When the patient had some gait problems, it may be because of ataxia, Parkinsonism or stroke. When the patient had some other systemic disorders like severe hypotension, severe anemia, fever, cardiac problems, even psychiatric disorders can present with the dizziness. And finally, the pure vestibular disorder, they will present with a real vertigo. So we need to ask the patient 3 simple questions. Was there any loss of consciousness? The loss of consciousness indicates that the patient either had syncope or seizure. Are you comfortable in the bed? So that means that the patient did not have any difficulty in standing and walking. So probably they would fit with the category 2 and 3, that is ataxia and systemic issues. Is it your leg is spinning or your head is spinning? So that is a real vertigo, that will belong to the category number 4. So what are the humors in medicines? An elderly man comes with a vertigo, and the doctor is checking blood pressure is 150/90. So saying that you have high blood pressure, so that's why you have vertigo. And another case scenario where a young lady comes with a vertigo and the blood pressure of 90/70, and again the doctor is saying that you have low blood pressure, that's why you have vertigo. See, we need to understand that unless extreme, both high and low blood pressure rarely ever produce vertigo, and we should avoid making these diagnoses. 62 years old lady, known diabetic and hypertensive with a very good control, presents with a dizziness, with a neck pain, and the vertigo is worsening with the neck movements, with lots of somatoform complaints also. The patient went having strict bed rest with a very overprotective husband, probably a very rare phenomenon to see, or he may be an actor, and she doesn't lift any weights. She was tried many course of vestibular sedatives and suppressants without any benefit. She started using cervical collar, which she refused to take it off even for the examination, and she volunteers the diagnosis of cervical spondylosis. When I made her to lie down for the examination, she developed a profuse vertigo, and she's saying that I told you so, doctor, and she comfortably lies down on the other side. Here you can see what I did for another patient with a similar problems. I'm doing a sideways Dix-Hallpike maneuver. I just turned the patient's head to 45 degree to the right side, and I made the patient to lie down, lie down on the left side. After a latency of few seconds, you can see that there was a horizontal with a torsional component nystagmus which was beating towards the left side. So that indicates that this patient had benign positional paroxysmal vertigo. And the patient cursed me for the correct diagnosis. So the final diagnosis is BPPV with the superadded anxiety symptoms. Can vertigo evoke pleasure in anyone? It can. The situation 1 is when you are a child. Situation 2 when you are riding, going for the merry-go-round and other rides. And finally, the physicians, when we learn how to handle dizziness in the emergency and outpatient department. Another old patient, elderly patient presenting with the dizziness, she had recurrent falls in the last 1 year. And in fact, he was afraid to go out of the house because of this dizziness. He tried many medicines without any proven benefit. MRI brain showed some atrophy in the brain, and MRI cervical spine showed some degenerative changes with some canal stenosis. He was diagnosed with various diagnoses like this: spondylotic vertigo, senile vertigo, and some patient, like somebody told he had a cerebral atrophic vertigo, which I never heard, and vertebrobasilar insufficiency. He was started on antiplatelets with the statins without any benefit. And he was describing he used to get some lightheadedness and some blackening, blackout of vision with some tinnitus, and he may fall sometimes, but usually happens when he suddenly gets up in the morning. There was no real spinning sensation, so this was a non-spinning vertigo. So it was just a dizziness, not a real vertigo. And when I checked the positional BP, there was a significant drop in both systolic and diastolic. So we all know that this is a case of orthostatic hypotension, which is often get missed, especially in the outpatient department. The differentials for the recurrent dizziness, orthostatic hypotension, cardiac arrhythmias, many times in old age, the complete heart block gets missed. So whenever the patient complaining of vague dizziness, always try to check the pulse and try to obtain one clear-cut ECG. And psychogenic, and we should not forget some medicines which can also produce dizziness, especially the older generation anti-epileptic drugs like phenytoin, carbamazepine, and lamotrigine, especially when it used for long time. Another patient, 40 years old, a diabetic, presented with a recurrent dizziness with unsteadiness, but she was saying that she used to be sensitive to light with a motion sickness also. She also gets occasional headache, which used to be throbbing headache, pulsatile inequality with nausea and vomiting. So here the diagnosis is vestibular migraine. How do you make the diagnosis of vestibular migraine? They should get at least 5 episodes of vestibular symptoms of moderate to severe intensity, which would last for few minutes to several hours, up to 3 days. And they need not necessarily have headache all the time with the dizziness. At least 50% of the dizziness episodes, they should have associated headache, and they should have either photophobia or phonophobia and visual aura. And this should not be better accounted by any other vestibular or other diagnostic headache. A 65-year-old diabetic lady presented to the emergency by her son, saying that she had a brief vertiginous spell, lasted for a few minutes and completely subsided. So she was explaining that like when she was trying to pick up at sambadam from the top shelf, she felt very dizzy. Luckily there was no fall and there was no LOC. Her husband already has been disabled with a stroke. Her son, being an IT professional, he did not want to miss out the treatable stroke like last time. And clinical examination was normal. When will you get vertigo? When you get the contradictory information from the vestibular system, that means ears, visual system, that means eyes, and proprioceptive system, that means muscles and joints. So here I will show you a small balance experiment. So when the patient is closing the eyes, there was no real problem. When the patient is lifting the one leg, there was no real problem. And when he was extending the neck alone, there was no real problem. But when he was like bending the leg, extending the neck and closing the eyes, he developed dizziness and he was about to lose the balance. So that means when you are like compromising all these inputs, generally you develop vertigo, and it is a normal phenomenon. That does not mean that the patient had a cervical spondylotic vertigo. And the two common tests which are very useless in the outpatient department, one is cervical spine X-ray and another one is carotid vertebral Doppler. And the eternal myth is vertebral artery producing compression and vertigo. It's a very, very rare phenomenon. And cervicogenic vertigo, it's a diagnostic uncertainty. Probably it is because of some mechanoreceptors in the neck, but instability on head extents is a normal phenomenon, does not mean cervical spondylosis or vertebrobasilar insufficiency. So don't try to make the diagnosis of cervical spondylotic vertigo, which is a very, very, very rare cause of vertigo. I will conclude with some diagnostic pearls. History is always very important. You need to ask the exact timing of the vertigo, whether it was acute vertigo or which was there for quite some time, what actually triggers the vertigo, and what is the duration of the individual attack, whether it is lasting for few seconds, that generally happens with the BPPV, or in a case of vestibular neuritis, it generally goes on and on, usually lasting for more than 24 hours. And we need to try to use this clinical algorithms like hints and standing algorithm, which will help us to differentiate whether it is a peripheral cause of vertigo versus central cause of vertigo. And always in a diabetic patient who presents with the dizziness to the emergency, try to rule out hypoglycemia and give thiamine before giving glucose administration. And when the patient is saying that he used to get dizziness when they try to get up, rule out postural hypotension, and always make it mandatory to check both the supine and the standing blood pressure whenever the patient comes to the OPD with either dizziness or vertigo. When they try to lie down or roll over in the bed, generally it indicates it's a benign positional paroxysmal vertigo, and the most common cause would be a posterior canal BPPV. And we should also keep in our mind that migraine is a great mimicker of all, especially a young female who is complaining of recurrent dizziness with occasional headaches. I hope you are not completely lost in this talk, and I once again thank you for the patient listening. Thank you.
Thank you, sir, for the enlightening talk. We will now hear a few questions from the audience.
So after eating potato chips, coffee, red wine, the patients get a spell of vertigo because of reactive hypoglycemia. What's your take on this?
As I told you that reactive hypoglycemia, it can produce vertigo. So we need to basically ask what exactly triggers the vertigo. So probably when the patient is saying that whenever they take these food products and developing vertigo, we need to rule out, we need to check the blood sugar to rule out is there any real hypoglycemia, and when it is there, then we can make the diagnosis of this reactive hypoglycemia in that patient.
Sir, one more common question we have faced. Some patients present with spinning of the head. Some people just spinning of the entire the surrounding. So will this history helps to make a central vertigo, peripheral vertigo, or among the peripheral vertigo it is any particular canal disturbance like that?
It will not help to differentiate whether it is a central versus peripheral cause of vertigo. The patient can develop either the spinning of self or the spinning of surroundings. That will not differentiate whether it is a peripheral or central.
Either way, but when we are scared to miss the central cause. We are peripheral cause benign, we no issues. Central cause we tend to miss. So is there any classical history to not to miss the central cause in the OPD?
Just the history alone may not be, if it is a pure vertigo. When you have associated features like when they had a difficulty in walking or difficulty in standing, because generally if it is a vestibular neuritis, they will be able to stand. Maybe they may have some difficulty in walking, but the standing may not be a problem. But if it is a central disorder, generally standing also may be a problem, even sitting in the bed also may be a problem. So I think that position will help us to identify whether it is a central cause of vertigo. If it is cerebellar disorder, they will have developed this truncal ataxia. So even in sitting, they will not be highly uncomfortable. They want to lie down. So that is why in the standing algorithm, they added this truncal ataxia to the hints. So standing algorithm will be helpful to differentiate whether it is central versus peripheral more than the hints test actually.
Regarding subclavian steal syndrome, sir, subclavian steal syndrome, any clinical point of this?
I think subclavian steal syndrome, the classic would be like when you are using the arm or doing exercise on one particular arm, especially the left arm, the blood flow will be diverted from the brain to the particular arm, so it creates a kind of dizzy feeling. Generally it will not be kind of a vertigo, so they feel more dizzy, and when you ask the clear cut history exactly what they were doing at the time of the dizziness, it will help you to clarify whether it is a subclavian steel phenomenon, and we can confirm that with a CT angiography that will clearly show stenosis in the subclavian, stenosis in the aorta after the origin of the vertebral artery, before the origin of the vertebral artery. Blurring of vision, it's not, it's because of that oscillopsy of feelings. So like when they have this vertigo, so they feel that the vision is not very clear. It is actually not loss of vision, it's not a clear vision. It's called oscillopsia because of the spinning feeling. They feel that the room is kind of wavering.
Okay, sir. Thank you so much. We shall now conclude this session.
Thank you.
Moving ahead, we would like to invite Professor Dr. A. Shanmugam, who will steer us through the complicated management of uncontrolled diabetes in the OP setting. Over to you, sir.
Good morning, everyone, and I thank DClub members, particularly Parandaman sir and Natarajan sir. Sir, please, sir. No problem, sir.
All of you know me. I am Dr. Narsingan. I would like to congratulate the DClub, which is conducting this DCCon. In fact, Dr. Parandaman has been repeatedly requesting me to come here. Though I am not in the faculty list, I thought I should come here and then try to see how he is achieving the goal of conducting a big meeting like this. Dr. Parandaman, thank you very much for calling me number one. And I am seeing all those younger people who are there with him to conduct a big meeting like this. I have been seeing them in DCCon in the past also, and I am really very happy to be here to have all your company. And I would like to congratulate Dr. Parandaman for inviting me here. Let me also congratulate him with a shawl here. Honor him. So nice that you have given me some opportunities.
Thank you, Narsingan sir, for your great gesture. And the topic we are going to discuss today, the clinical approach in the management of uncontrolled diabetes in the outpatient care. Once Dr. Parandaman sir told me the topic. Usually we give a talk on any scientific article or any research paper or the evidence-based medicine. But this is a day-to-day clinical practice we come across in our clinical practice. So it is not only the science also, it is also from the experience what I have learned over a period of 1.5 decades in the almost 2 decades in the field of diabetology. So whenever we are treating a diabetic patient, we should keep in mind this natural history of type 2 diabetes mellitus. We know that diabetes is a progressive disease, even though we never talk about remission, all these things, but nevertheless diabetes is a progressive disease. So beta cell decline happens over a period of time. We need to intensify medications as needed, and sometimes we can be able to manage insulin resistance by way of lifestyle modifications, weight loss. That also helps to bring down the sugar levels. And we should keep in mind that the incretin levels also fluctuate as the diabetic duration progresses. So approach to persistent hyperglycemia, we divided into glycemic approach and non-glycemic approach. Glycemic approach, we talk about diagnosis of diabetes, whether are we dealing with pure type 2 diabetes, or whether we are dealing with some other medication associated with, is there any way to help the fluctuation, are we missing something in the bus, and non-glycemic comorbid and complications, lifestyle modifications. So my flow of talk will be main of experience with the evidences whatever I gained over a period of 2 decades. So the causes of rising hyperglycemia, these are the evidences already we have known, and progression of underlying disease progression, which already discussed here. So type 2 diabetes mellitus is a progressive disorder. Usually it goes that is why we ask the patient to come frequently to up-titrate to the dose or down-titrate the dose as per requirement, and decrease adherence to the exercise, diet and medical regime. That is also a common problem in our clinical practice. This also increases the blood sugar, and we know that weight gain increases insulin resistance, and that also increases the blood sugar levels. And intercurrent infections, and even with the mild infection of dental caries, or anywhere wherever the patient have some even a melanobacities or any infection, can aggravate blood sugar levels. That is also a known factor. Stress and depression also will aggravate blood sugar levels. The use of medication which can alter the glucose metabolism also increases the blood sugar levels. And undiagnosed type 1, many times we diagnose as a type 2, the patient tend to be a LADA, later onset diabetes in adult group. So that also will elevate the blood sugar irrespective of oral medications what we use. Unless we use insulin, this patient cannot be well controlled. And therapeutic inertia. Many times patient they have their own explanations. Sir, I have one sweet 1 month before, I skipped a tablet for 2 months before. And we the patient's inertia sometimes we not should have for the clinicians. We should have a very strict glycemic control. Unless we don't have any inertia, we can't able to bring down the blood sugar levels. And look for secondary diabetes, particularly associated with the endocrine anomalies. So diabetes patient never comes only with the diabetes. They also have a thyrotoxicosis, acromegaly, or sometimes Cushing's features can be associated. So we have to look for always secondary thought. And most common will be the non-compliance. And the patients skip the food or skip the tablets the day before the test, on the day of the test, postprandial, most of the time they skip the tablet. So unless we specifically ask for it, whether you had a tablet the day before the test, whether you had a good sleep the day before the test, whether you had a tablet on the day of testing the post-breakfast, all these things will, even though a simple question, definitely will help us to address the hyperglycemia. And as experience says us, diet, sleep and lifestyle modification. Definitely patient doesn't have good sleep the day before the test, definitely the fasting will go up. Many times patient will have a heavy lunch or heavy dinner the day before the test. Without asking that, we tend to increase the dose. And that is why the HbA1c helps here. If a patient have a fasting elevated sugar, HbA1c is quite good. We should ask for what happened yesterday night or the day before the test. Whether the patient had a sweet or a patient had a irregular sleep pattern, what is that? Or sometimes patient missed a week of exercise also elevate the blood sugar levels. So, my professor used to say that diabetes management not simply increasing the dose or decreasing the dose. We should ask for the detailed history, particularly diet, sleep and exercise. And weight and BMI obviously we do monitor. And medication adherence, that is a common scenario in postprandial glycemic control. Many patients, even today a well-educated patient will do a postprandial blood sugar without taking the medications. The purpose of doing the test is whether the tablets are working or not, whether need to increase the dose or decrease the dose. That is our main purpose of the test. So we have to educate our patients that we should take medications with the breakfast, whatever the medications patient on, unless we are going for C-peptide assessment. And insulin injection technique and site inspection. This is the most common practice we should go for. In a busy practice, diabetic practice or busy any clinic, we increase the dose of insulin. We never look for the injection site. We never look for the technology, what techniques they use. Sometimes patient to use this 40 ml vial, 40 units vial, they take insulin from the 100 U syringe. The mismatch also happen. Sometimes patient we prescribe pen, patient doesn't want pen. They are very comfortable with the syringe. Sometimes I have come across the patient has taken the insulin using the syringe from the pen. From the cartridge they will take. It will be overdose. So we have to be techniques, even though we tell them, we teach them in the first visit, whenever sugars are not as expected, we have to check whether the insulin techniques are happening correctly or not. And injection site, particularly whenever patient have a lipodystrophy, lipohypertrophy, patient definitely have uncontrolled hyperglycemia unless we change the site. And any infective foci. That is what we have discussed. And surgery, if a patient well controlled, they ask going for some simple cataract surgery, the sugar will go up. If you want to have a very good control, every week you do, patient will go up. So even a simple stress, just for cataract surgery also sugar will go up. And most common thing is, another thing is dehydration. If a patient dehydrated, definitely sugar level will go up. We know the science behind this. And whatever insulin we take, subcutaneous will not be well absorbed if a patient have a severe dehydration. And drug food test mismatch, what we discussed, drug adverse reactions and associated complications. We know that liver disease and renal disease will have hypoglycemia. Very rarely these two conditions also have hyperglycemia as well. So the first common thing we should address is a diet recall. Many patients, still if you ask for, many patients will taking kanji, porridge in every day, thinking that it is a good for our diabetic patients. So unless we look for diet, unless we look for diet recall, we can't able to, we tell the diet, what diet to be followed, but we don't know what diet patient is following. We have to ask for what diet you are following, then we have to adjust the dose. That is a major important area we can able to control the blood sugar. And exercise pattern. Have you skipped exercise? Are you going for regular exercise? What is the exercise for pattern you follow? Many a time patient will have some osteoarthritis which they don't follow exercise. We can allow them for yoga, some other modality to go for some lifestyle changes. And drugs and hyperglycemia. We know that fluoroquinolones, which though gatifloxin not available in our market, fluoroquinolones, protease inhibitors, pentamidine definitely alters the blood sugar levels. And first generation, second generation antipsychotics, particularly the second generation antipsychotics will increase diabetes. Even sometimes they can present it with DKA itself. Clozapine can, olanzapine can precipitate diabetic ketoacidosis in a type 2 diabetic patients. And beta blockers, thiazide diuretics, vasopressors, diazoxide, all these drugs can aggravate hyperglycemia. And this glucosteroids, this is a common scenario we come across. Whenever the patient go for any other illness, if some other doctor prescribes steroid, definitely the sugar levels go up. If a patient having thyrotoxicosis, patient having dose of thyroxine, they are taking very high doses, that patient also have hyperglycemia unless we specifically address that. And latest immunomodulators also attacks the beta cells, they can also have hyperglycemia. So the drugs has to be addressed, associated any medications patients are taking, and diet and recall. If everything is perfect, and look for the technology, go with the technology. You go with ambulatory glycemic monitoring, so you can able to know that whether the patient is taking the right medications, what is the diet if they are missing, and what time the patient is going for hyperglycemia. This is a fantastic tool to help us when the patient is going for hyperglycemia, particularly in the nocturnal hyperglycemia. Many patients after post breakfast, the post dinner sugar levels go up. So those who are following pregnancy diabetes, those who are going for glycemic profile will be able to understand what I am telling. The postprandial hyperglycemia, particularly the post dinner time, definitely go up. Unless you look for AGP, we can't able to predict. And HbA1c, this is a fantastic tool, help us whether the patient taking medicines rightly or not, or skip the medicines or not. So we should understand the fallacies of interpreting HbA1c whenever we are believing only by HbA1c. We have to look for hemoglobinopathies and hemoglobins. And remote monitoring devices also available to help us to understand what is the patient is going for. The non-glycemic, not only the medications, the depression, euphoric symptoms also aggravate hyperglycemia. Unless you address depression, we can't bring down the sugar in many type 2 diabetic patients in a clinical scenario. This group of patients always complaining. So you have to specifically look for these patients. And physical examination is the most important part. So apart from the history, we have to look for physical examination of any foci of infection, dehydration, or thyroid swelling or thyrotoxicosis, any other associated illness, we have to look for it. And laboratory, obviously, HbA1c, urea, creatinine, LFT will help us whether the patient is going for any complications. And always go with the rules and regulations strictly to follow good glycemic control. This is the ADA, American Diabetic Recommendation. Every year ADA comes with a good recommendation, what to follow and what to not follow. We know that first line of therapy is always metformin, which is a gold standard therapy. Still $1 million question, what is after metformin? Sulfonylurea, DPP, GLP, SGLT1. If you ask anyone, we go with the individualized therapy. But the baseline is after metformin, whatever drug you give, HbA1c control will be equal. This is published in 2002, even though it's an older study. The recent study which published in 2022 also suggests that after metformin, whatever the drug used, sitagliptin, glimepiride, liraglutide or insulin glargine, HbA1c levels will be equal. And all the drugs will have a HbA1c reduction. 70% of people you can able to achieve good glycemic control, whatever the drug you use. But as per the natural history of diabetes, many a times the patient loses glycemic control as a period goes. So whatever the drug use, nothing wrong. So we should have a pharmacokinetics and pharmacodynamics. Why I am using these drugs? Why I should not use these drugs? This is a concept we want to have whenever we are addressing HbA1c reduction. So HbA1c reduction, we know that insulin will be the wonder drug to bring down the HbA1c reduction. Whenever nothing works, insulin always works. So whenever you are having a persistent hyperglycemia, no other drug works, go with the insulin. Insulin also helpful in early type 2 diabetics mellitus to induce remission. That is also a well-known concept. These are the recommendations available, what insulin to go with, whether to go with Basal or go with Prantial or go with Basal Plus, whatever you go, but you should know the pharmacokinetics and pharmacodynamics so that we can able to achieve a good glycemic control. Whether choosing GLP-1 or GLP-1 SGL2 inhibitors, these are the latest recommendations, so many recommendations having, but one of the good recommendation from to follow the rules and regulations from the American Association of Clinical Endocrinology. They specifically target which focus you are going for. Are you going for glycemic control? Are you going for efficacy? Are you going for renal safety? Are you going for obesity control? These are the focus, the latest recommendation of American Clinical Association of Clinical Endocrinology. So the choosing the right drug to achieve good glycemic control based on the recommendations, based on the trials, safety and comorbid and the cost. Even though this is a simple one, cost is the most important one. Unless we associated with the patient, if we have to go with the patient preferences, if I write semaglutide the patient, definitely patient will not take the tablet or patient will skip the doctor, change the doctor. This is also one of the common reasons for persistent hyperglycemia. So the main goal of type 2 management is always cardiovascular renal risk reduction is the major focus of therapy. Keep in mind that, this is my own protocol. If you want, you can go with, if you're focusing on atherosclerotic cardiovascular disease, go with SGL2 inhibitors, GLP-1 receptor agonist, DPP-4, last only glinides and sulfonylurea for outpatient clinical management. If you focus on heart failure, go with treatment with the patient with heart failure, go with the SGL2 inhibitors followed by GLP-1 receptor agonist, and rest of the drugs follow the later, and not to use pioglitazone. And if you are focusing on CKD, SGL inhibitors, incretins and TCD sulfonylurea will be the last option. If you go with efficacy, obviously the sulfonylurea took over. This is one of the efficacious molecule, as insulin also most efficacious, and DPP-4, GLP-1, SGL2 inhibitors are modest effective drug. GLP-1 you can put it in between insulin and DPP-4 inhibitors. And cost, if you're looking for the cost, obviously there is sulfonylureas which is cheaper. Nowadays we have a good SGL2 inhibitors, also generic molecules are also available, and incretins also available as a cheaper molecule, so you can go with these molecules. And weight loss will be your primary focus. You go with SGL2, GLP-1, DPP-4, sulfonylurea, insulin or TCDs. And if you want to avoid hypoglycemia, these are the choices of drug in our outpatient clinical settings. So approach to the management, we should go with the cost, goal, safety, adverse, comorbid and the patient preferences. But if you go with this systematic way, definitely we can able to approach hyperglycemia in our outpatient patients. This is a common, to summarize whatever I talked, this is 5 or 6 points we should focus on in outpatient clinic. Review the patient history. If a patient have uncontrolled diabetes mellitus, sit with the patients, ask for spend 5 to 10 minutes, ask for the history and whether the patient taking regular medications, good sleep, proper dieting, and whether unbiased clinical examination. Think of whether the patient have any other secondary diabetes. Are you missing anything, particularly acromegaly, Cushing's? Are we missing anything? Check for any other medications patient is taking. And second, always have a second thought of secondary diabetes. Many times we miss chronic calcific pancreatitis, many a time we miss thyrotoxicosis induced hyperglycemia. And look for glycemic pattern. If everything is perfect, look for glycemic pattern. Whether the patient is skipping the drug or a patient having glycemia post dinner or post prandial or post lunch or nocturnal hyperglycemia, unless we address that, we can't able to bring down the HbA1c levels to the target levels. And modify the metabolic obesity. Always